Hello, everyone. Welcome to another show, The Dr. Dustin Show. Today is the International Fibromyalgia Awareness Day. So if you have fibromyalgia or you wonder if you have fibromyalgia, you are in the right place and we recognize you today. Fibromyalgia is one of those crazy diagnoses that's sort of been around and developing over the decades as far as just being able to recognize it. I mean, imagine the frustration of living with a condition for so long, wondering, is it just me? Am I losing my mind here? Why am I feeling this way? Why do I feel like every morning I get up, I feel like I got hit by a semi-truck, right? This is what people with fibromyalgia can experience, and obviously extremely debilitating condition. And that's why we recognize it. We want to bring awareness to this so that we can further the research, further the understanding and the validation for these patients that live with it every day. According to the CDC, about 4 million people in the U.S. actually live with fibromyalgia. Now, that's about 2% of the U.S. population. And the way we sort of categorize it or think about it is, yes, widespread pain, that is pain on both sides of your body and above and below the belt. And it can be quite severe, but we're not just talking about pain like maybe a person without fibromyalgia experiences pain. No, this is really quite different. People with fibromyalgia experience pain when they shouldn't experience pain. Even the brush of a hand over their arm may cause sensitive feelings, like as if they have a sunburn. Their muscles may feel extra sore, like even if they just went to the grocery store and loaded their car with groceries, they can pay for that the next day. It's like, man, did I just run a marathon? No, you didn't. Things that are supposed to be painful can be extra painful. We call that hyperalgesia. So, let's say you did get a sunburn. By golly, you may just be hospitalized because of how severe that pain is. And it just feels like, compared to everyone around you, you're just struggling a lot more. And not only can that be, affect your own psyche, but it can affect just your whole quality of life, your whole outlook, your whole understanding of what your body's doing. And so, yes, there is pain, but even more than that, fibromyalgia deals with cognitive changes. We call it fibrofog or brain fog, right? Short-term memory problems. Oh, where did I, leave my keys? In conversation with other people, it can be challenging. You might struggle to find the words that you want to say. And of course, that will very quickly make you not want to be in social situations anymore. This type of brain fog can lead to depression and anxiety and isolation. Beyond that, there's other syndromes that go along with it. There's other central pain syndromes such as migraine headaches, irritable bowel syndrome, and other conditions as well. Rheumatoid arthritis, lupus, other autoimmune and inflammatory conditions have been associated with this condition as well. So it's really a challenging thing to live with, because also it's a challenging thing to pin down, and that's the joy of it. When you go to a doctor, you say, hey man, everything hurts from the top of my head to the bottom of my toes. Well, okay, let's get some lab work and maybe some imaging, and we'll get this done and, circle back in about 2 weeks. Okay, great. You come back, and you hear those dreaded words. Well, it looks like everything is normal. Oh no, I can just think of the heart just dropping in your chest. Well, then what? If everything is normal, you don't think I'm making this up, do you? Right? Like, that's the immediate thought that might go through your head. And the answer is no, we don't think you're making this up. At least an educated, insightful physician these days should not believe you're making it up, not by any stretch. Fibromyalgia is well recognized now, thanks in part to days like today. So if everything looks normal, I hear a lot from the audience. And by the way, if you're a new subscriber to this channel, welcome. I know we've had maybe a dozen or so just in the last few days. So if you're watching this for the first time, we're glad you're here. Do leave us a comment. Let us know that you're here and what you're looking for, and maybe we can see how we can bring you the information you need. But I do get a lot of questions from the audience, isn't there a blood test for fibromyalgia? What's going on with that? So I actually had to look it up because we don't do it typically for patients. It's called the FM/A test. I believe this is the same test you all are referring to. And essentially what it is, you take your blood, you run it through the lab, and you look at the monocytes. Monocytes are a type of white blood cell, and those monocytes are stimulated in vitro, and then they release a chemical, also known as a cytokine in this instance. And we measure, the laboratory people, they measure the amount of cytokine response. And it gets sort of passed through an algorithm, and it comes up with an answer that you are likely or unlikely to have fibromyalgia. The problem with this test, Kevin, if you can pull up that first image, is that it's not very useful, essentially. And you can see here on the chart, the two studies that looked at this test to validate it, one was comparing fibromyalgia with healthy controls. And as you can see there's a sensitivity of 93%. That means that those with fibromyalgia, 93% will test positive. And an 89% specificity, which means those without the disease, 89% will test negative. Now, you might think that's pretty good, and it is, but the problem is we're comparing healthy controls with those known to have fibromyalgia, so it sort of overestimates the accuracy of this test. That's not how we would use this test in real life. The second test gets a little bit closer. We can see we're comparing fibromyalgia patients with rheumatoid arthritis or those with lupus. The sensitivity stays the same, meaning that 93% of those with fibromyalgia will still test positive using this test. But the specificity goes down. And that makes sense because now we're including a population of rheumatoid arthritis and systemic lupus. So again, are these really practical in real life? From my perspective, the answer is no. Really what we should be doing is testing those with known fibromyalgia and then comparing this test with those who have suspected fibromyalgia, because that's the whole point why you would want to do the test if you suspect it, right? And fibromyalgia is not a diagnosis of exclusion. It used to be. It used to be, well, you got to rule out all these other things in order to qualify for the diagnosis of fibromyalgia, but not so much anymore. We understand that horses can run with zebras. In this case, you can have rheumatoid arthritis and you can have fibromyalgia at the same time. So again, what is the utility of this test? I don't really know. I mean, if it comes back positive, okay. If it comes back negative, okay. Is it going to change our management? Maybe, maybe not. A lot of insurances apparently will pay for this test. Otherwise, if you want to pay cash, I guess it runs around $1,000 if you're interested. But again, I don't know of any study to support a real-world application for this test just yet. So if some of you have a different experience or a different article you'd like to share, do send it my way. But as of yet, I don't think this test has hit mainstream. So how do we diagnose fibromyalgia? Well, of course, the American College of Rheumatology came out in the 1990s, early 1990s, with their very rigid diagnostic criteria, and it was based on a set of tender points. And you had to have more than 11 out of 18 pre-specified tender points on exam to qualify for the diagnosis. However, it was great for research, not so great for real life, again, because it did exclude a significant number of people that were likely on a spectrum of fibromyalgia rather than the very end or the very extreme. And so, again, that was good for research because we really want the extreme cases for research purposes, but not so great for real life. And so the criteria has evolved over time in 2010 and 11, and then again in 2016. And now the diagnostic criteria is based on more of a whole person approach. It takes into account the entire experience. The fatigue, the brain fog, the cognitive changes, mood changes, other symptoms that might be related to your gut, and other conditions. And then it comes up with a whole score. And there can be a range of where you fall on that score, whether you are diagnosed with fibromyalgia or not. So that seems to be a lot more inclusive and a lot more accurate, I think, to the patient's experience. And like I mentioned before, it's no longer really a diagnosis of exclusion. You can have other conditions and still have fibromyalgia. And I think that's huge, as it can be validating and also lead to more appropriate treatments. Now, there are some risk factors, of course, for having fibromyalgia. It is somewhat of a unique disease in the sense that, osteoarthritis, joint disease, degenerative joint disease, back pain, almost affects everybody across the board. Fibromyalgia is unique in the sense that it really only affects women. Yes, it can affect men to a smaller degree, but 80 to 90% of people with fibromyalgia are women. I find that to be fascinating. And it actually reminds me of the study we talked about in our last podcast, the study that was published this year in Science Immunology, where they were looking at mice and monocytes. Again, we're back to the monocytes, and how women generally experience more pain than men across the board. And one potential mechanism might be the fact that men produce more monocytes, and those monocytes produce more interleukin-10. All of that seems to be testosterone driven. And for whatever reason, in my studies and even paralleled into the human world, they find that that's a predictable mechanism for more rapid recovery and less pain overall that men seem to be privileged with, at least compared to women on a large scale. So fibromyalgia seems to be no exception to this. Some other risk factors, which maybe you heard me promo today in my TikTok, was the presence of autism or ADHD. Under one umbrella, we'll call it neurodivergence. And this was fascinating to me as well, but it made sense the moment I started to understand it, because neurodivergence is essentially a pain processing problem, right? And autism, neurodivergence is a sensory processing problem. Fibromyalgia is a pain processing problem. And so, one way to understand this, because a lot of us are visual creatures, visual learners. If I go out to reach for something, okay, there's the logo. I'm going to go out and touch the logo, right? I have muscles that are being told what to do by nerves in my arm, but also in my spinal cord and also in my brain, and different parts of my brain as well, if I might add. And so for me to control my fine motor movement and stop right there over the logo, that takes a lot of inhibition, actually. Yes, we're activating the muscles, but to create such a smooth movement and to stop right where I want it to, it takes a lot of inhibition and coordination among different levels of nerves, not only in my arm, but also in my spinal cord and multiple parts in my brain. And so you can imagine any disruption to any of that can create different abnormal movements or ataxic movements, right? I can shake as I go. I can overreach. I can move very quickly, or I can move very slowly and almost never get there, right? So we don't often think about that. The movements that we make, we take it for granted, I think, in a lot of cases, just moving through life. But if you are so blessed to have a condition where that process is affected, then you understand how much maybe we took for granted before, when movement is no longer under our fine motor control. Well, that's basically what's happening with sensory input at large, including pain, right? We have parts in our spinal cord and multiple parts in our brain that inhibit those pain signals and inhibit those sensory signals. Just in the same way, you could be sitting here watching me on the couch and you're not aware of the fact that your butt is touching the couch, Well, you are now because I'm telling you, but 5 seconds ago, it was just being inhibited. Imagine being so sensitive to everything that it hurts to feel a breeze come across your skin, right? That's what some of these people with fibromyalgia are experiencing. And from a general sensory perspective, that's what these folks with autism also deal with on a daily basis. And you can imagine the contribution to the emotional dysregulation as well. The challenges in communicating what your pain is or what it feels like. There's so many broader concepts that then fall underneath this experience that once you understand it, it does make a lot of sense. Some researchers have found that autistic adults are up to 4 times more likely to experience chronic pain conditions, including fibromyalgia, than their neurotypical counterparts. One study reported that 60% of autistic adults had central sensitization symptoms, and those symptoms were higher than the clinical cutoff on a standard questionnaire. So 21% actually met the formal diagnostic criteria for central sensitization syndrome, but 60% were past the typical threshold. So that, again, is very descriptive and consistent with the idea that fibromyalgia and those living with autism have a disorder of sensory or pain processing and sensory amplification. Why is this important to know? Well, of course, validation, education. The more we know, the more we can research, the more treatments we can find. But also, imagine if you feel alone in this fibromyalgia diagnosis and nothing quite seems to add up. Maybe there could be some autistic component to it. And hey, a diagnosis in that way can lead to further therapies that may help your overall quality of life. So it is important to understand these connections and see if there's a link there for you. So what about the endocannabinoid system? This is definitely getting a lot of talk in the pain community, and I think rightfully so. The endocannabinoid system has been well described for several decades now. It's essentially a sophisticated neuronal network within the brain and the spinal cord. And just like the opioid system, just like the serotonin system or the dopamine system, we have an endocannabinoid system. And so there are chemicals in our brain, neurotransmitters, that we refer to as endocannabinoids, and there's receptors, endocannabinoid receptors that receive these chemicals and then, of course, create a downstream effect. A lot of the endocannabinoid system is responsible for, well, numerous physiologic processes, but including pain perception, mood, appetite, modulating the inflammatory response. It's really critical, you might say, in maintaining the homeostasis of the body, much like a lot of other symptoms, of course, but the endocannabinoid system is no exception. Kevin, let's show the next slide here. I have a picture of the 2 endocannabinoids that I'm going to reference today. When you research the endocannabinoid system and really anything that you're trying to link it to, these are the 2 main ones that people talk about, which AEA and then 2AG. I just put that up there for your reference. There won't be a quiz after today's show, but there you go. So 2AG and AEA for your reference. These are the 2 main ones we talk about in the clinical research. Actually, so this is some organic chemistry. We actually had to, I think all the amino acids and then some in college. We had to memorize the organic chemistry shapes, just like you see on there on the picture, and draw it all out for our final test. That was definitely useful in real life. Yeah, I can say that. No, it wasn't. But anyway, the theory behind the clinical endocannabinoid deficiency. So this is what we sort of talk about when we're referring to this system as being a cause in, let's say, fibromyalgia. So research indicates that alterations in this system, specifically levels of the endocannabinoids, of those two that we referenced here just a minute ago, can contribute to increased pain sensitivity and other symptoms observed in patients with fibromyalgia. In fact, this is a rather strong link. And so then the question must be asked, if we have a deficiency in endocannabinoids, would supplementing with cannabinoids be helpful, right? And for those of you that don't know what cannabinoids are, you can smoke it. All right, I'll just leave it at that. So there was a survey that was conducted in Israel in 2018. I thought this was pretty interesting. And it revealed 84% of patients with fibromyalgia reported cannabis use. 94% of those experienced pain relief. 93% observed improvements in sleep quality. 87% reported reductions in depressive symptoms, and 62 revealed improvements in anxiety. So, of course, this was just a cross-sectional survey. It's not a randomized controlled trial, but definitely some interesting reports there. Another research study conducted in 2019 showed that cannabis therapy led to a substantial reduction in pain intensity and an increase in quality of life for patients with fibromyalgia. So this study actually found 50% pain, a reduction of 50% in pain in 81% of patients for 6 months. That is after 6 months of treatment with cannabis therapy. So definitely some more confirming research there. I'm not saying cannabis is the answer for all fibromyalgia, but it's definitely worth looking into. There are some drawbacks, of course. I would be remiss to ignore the fact that cannabis products are not legal anywhere or everywhere in the U.S. or even in the world. So, of course, there is an access issue. And then even in places where it is more accessible, there's differences in type, quantity, dosing, how you take it, right? And so it does make it challenging to recommend this treatment as a physician and as a physician who maintains liability, as well as wanting the utmost safety for my patients. So, until that's more standardized, you're probably not going to get a recommendation from a physician. However, the growing body of research is fascinating to look at, and hopefully leads to some more mainstream therapies in this regard in the future. So that's my take on that right there. I'm on board with it. Whether you're going to get me to officially recommend it or not, I don't know if we're there yet. Of course, there's other treatments I'm sure many of you already are aware of. Exercise, cognitive behavioral therapy, acceptance and commitment therapy, right? A lot of this is nociceptive, centralized sensitization type pain. And so any type of mind-body interventions, while perhaps not curative, can certainly be supportive in this measure. Biofeedback, stress management, again, huge. Why? Because stress is such a huge trigger for fibromyalgia flares, and knowing how to manage your triggers can be a huge thing. And again, managing, I mean, live with, right? Not practicing avoidance, because again, avoiding life is no way to live life. There has been a huge focus on sleep as well. Going back to people with autism, they experience similar disorders in sleep architecture the same way that people with fibromyalgia experience. And so there's a huge problem with trouble sleeping, but non-restorative sleep, waking up feeling tired. You ever see those commercials? Have you ever woken up feeling tired? It's like, yeah, all of us.
All the time.
Yeah, right. But people with fibromyalgia experience that on another level. And it's not something they can really recover from. Lots of people stay up too late, eat too late, do whatever they, do to wake up feeling tired. But people with fibromyalgia do everything right and still wake up feeling crummy. So that's sort of the difference there. And again, focusing on sleep in and of itself can be a huge therapeutic approach. So I'm going to get to that here in just a minute. The medications, of course, I am a medical doctor. I have my doctorate in medicine, and so we're going to talk about medicine. But again, it's not, I would say, curative in and of itself, but it can be supportive. As you've probably realized by this point, fibromyalgia affects every sector of your life. And so one particular medication for one particular receptor, again, may be missing the big picture, but it can be definitely a piece to the puzzle. Lyrica was the first one, pregabalin, to be FDA approved by the FDA. That was in 2007. Duloxetine came a year later in 2008, and then followed by the much more expensive sister of duloxetine known as Savella or milnacipran, came in 2009. And so that's pretty much what we were dealing with as far as FDA-approved medications for the last, 15, 20 years almost. Until 2025, we had our first new medication that came onto the market for the purposes of treating fibromyalgia. That is, of course, Tonmya, also known as sublingual cyclobenzaprine. So when the rep came into my office, she's like, "Have you heard about our new medication, Tonmya, for FDA approved for the treatment of fibromyalgia?" I was like, "Oh, they got a new medication for fibromyalgia. That's great. We haven't had one in a while. And what's the active ingredient?" She's like, "Well, it's cyclobenzaprine." I said, "Oh, okay, so it's Flexeril." Oh, we've been using Flexeril since the dark ages. And she's like, no, it's not Flexeril. Well, technically you're right. It's not Flexeril. Flexeril is a pill that you swallow. This one is a pill that you put under your tongue. Okay. Well, what's the difference? The difference is dosing. It's a little bit different of a dose as far as milligrams go. And it's sublingual. So the theory is it has a much greater access to the brain. It crosses the blood-brain barrier with greater ease. It doesn't have to be absorbed through the GI tract. So you get better effect from it. Okay, cool. So let's look at the research. Again, I don't have much experience with this medication. It's, again, a really new medication. If you have tried this medicine, let me know in the comments. I would love to know your take on it. But here's what the research shows. So there were three big studies that they looked at. Two of them met their primary endpoint. This is one of them that met their primary endpoint. So you can see on the left-hand scale, there is a change, an average change in the pain scale. So a pain scale meaning 0 to 10, we're all familiar with. And so we had a placebo group numbering 225 participants. All diagnosed with fibromyalgia. And then we had the active group who received the Tonmya, and that was 231. And you can see over time, the bottom row being weeks, their average daily pain intensity scores reduced. All the way to the end there, we have 14 weeks is how long this trial was. The placebo group, on average, their pain reduced it reduced by 1.2 on that scale of 1 to 10. And the active treatment group reduced by 1.8. So, honestly, a 1.8 reduction in pain is notable. That's pretty cool. A 1 point on the scale is considered clinically significant. Many of you might say, I'll take a half a point if it reduces my pain. But for research purposes, we tend to rely on just 1 point on that scale of 10 to be clinically significant. This almost was 2 points in reduction at 14 weeks, which is pretty awesome. What's interesting is the placebo was 1.2 also 1.2 in reduction. So the active group was not significantly, well, let me take that back. Statistically, it was significant. Even compared to placebo, there was a difference in that, but it's still fascinating to see the placebo reduce pain by 1.2. So there you go. But yeah, so have you tried Tonmya? I would be curious to know. The big benefit really with Tonmya, I think, is sleep. And that was the focus on it. And there's some other outcome measures that I didn't put up on the screen because really it could be a whole lecture in itself. But sleep was a big deal in how this medication worked. And, there you go. I think if we can sleep better, or even if we're taking a placebo, but we think that we can sleep better, just having that knowledge of something better coming, I think, can be therapeutic in and of itself. So that seems to be the most recent updates on fibromyalgia. We were developing or understanding and promoting new links to different things. Of course, we have autism and neurodivergence as a whole being some connection there, ADD or ADHD being connected. And by the way, this is a little bit off topic, but neurodivergence has also been, I know some of you are probably waiting for me to recognize this in the comments, but yes, it has been associated with other things as well. POTS, dysautonomia, Ehlers-Danlos syndrome also. And so for some reason, there seems to be a connection between these things and how the nervous system functions, its control over the immune system, monocyte production, interleukin production. So yes, there's so much more to understand about pain and what causes it and how we experience it and how we can treat it, that we could just talk forever on. And I think that's good news. I think that's good news because what I want it to be is validating. I want it to tell you that, hey, maybe there's more to this than meets the eye, and that's okay. And we don't know everything. We don't know everything. We're going to keep asking questions. We're going to keep pushing the needle. And hopefully one of these days we find treatments that just, it's the magic pill. It does exactly what we want. So, wow, look at these comments. Lots of comments in here today. I'm going to go ahead and get into these here real quick because I appreciate you all joining us on the live tonight. Let's take a look. All right. Yes. Jamie Bates says, fibromyalgia is like waking up to the worst hangover for the worst of your life. Yes, exactly. Like getting hit with a semi-truck. I've definitely heard patients say that, and not a great way to start your day, if I might add. Kate Bakes says, I have central sensitization, but not fibromyalgia. Feels like sandpaper on my skin some days. Just wearing clothes. Mine is from untreated chronic pain from EDS, joint dislocation, and GI pain. Yes, right. And that's a good point. You can have central sensitization without meeting the criteria for fibromyalgia per se. But yes, it probably all exists on a spectrum. And by the way, I've experienced that as well. I notice if I work too much or I'm extra stressed out, not sleeping much, not monitoring my diet, I will get patches on my skin or like maybe on my wrist, sometimes on my foot, and it feels like a sunburn. Like I'm not sunburned, the skin looks fine, there's no deformity, no rash, no discoloration, but it just hurts. And then it hurts more when I touch it. I chalk that up again to stress being a trigger for this type of sensory amplification. Probably part of my brain is saying, hey, I need to rest and regenerate, give me some nutrients. And after a couple of days of taking better care of myself, it does go away. So not saying I have anything similar to what you guys might be dealing with, but I think some of that, it might be a taste. It might just be a taste of how stress can be a trigger for those symptoms. Let's see here. The Mayo program treats it like a mental health disorder still. That's interesting that you bring that up. I'm not going to disagree with you. I have watched a few of their things on fibromyalgia. I think they have a podcast that talks about it. Yes, there are a lot of, let's call it mental health treatments that can be very helpful for people with fibromyalgia. But to treat it totally as a mental health condition, I think really is missing the boat and invalidating, I think, a lot of patients' experience and probably ignoring a lot of the physiology also. I've been diagnosed, Jamie Bates says, I've been diagnosed with endometriosis and Raynaud's, which are often diagnosed with fibromyalgia. Yes. I don't remember if endometriosis is included on that very long questionnaire that we use to diagnose it, fibromyalgia with, but I know Raynaud's is. That definitely can have some overlap with fibromyalgia. Raynaud's is scary. I've seen some pictures of it. It does not look pleasant. I've had some patients actually, not a lot, but some come in with it, and you're like, hey, my fingers are all like ghost white, and the rest of me is normal looking. Is this normal? I'm like, no, that's not normal. Rub it under some warm tap water, see if we can get some blood flow going. But I mean, there are some medications for it, some treatments for it, but yeah, that can be unpleasant to live with, to say the least. Jamie Bates says, besides increasing cytokines, my understanding is low ferritin and low vitamin D are also common in fibromyalgia. Yes, ferritin or low iron stores generally can overlap with the symptoms of fibromyalgia. Vitamin D has been pretty much associated with almost every single pain condition that we know of. Almost all of us are vitamin D deficient. Of course, it is considered to be a hormone. It does play a role in inflammation and a sense of well-being, your health in general. So yes, if you haven't had your vitamin D checked lately, I would highly recommend that you do. They have studies, dude. What am I, a doctor? Okay. Man, guys, they have studies that show just by replacing your vitamin D can be helpful in reducing pain scores. So there you go. Many EDS patients who go on to go on testosterone, I think is what you're referring to there, have reduced pain as well and slower progression in our disease. They haven't figured out why. Yes, for EDS, I'm going to suggest, I don't know why exactly, but based on how I understand the physiology, we know testosterone is vital in patients who are maintained on long-term opioid therapy. And the reason why for that is because testosterone allows the opioid receptor to function. And what's also unique is that opioids themselves will reduce the levels of testosterone. So it's like a catch-22. And so, patients may find that over time, the longer they take opioids, maybe their pain is getting worse. And so then the patient and the doctor might incorrectly assume that there's a opioid tolerance developing, or even that the pain is just getting worse on its own, which may be true, but I think maybe an undiagnosed or often undiagnosed issue could be the fact that the long-term opioid therapy has caused testosterone to diminish, and then that reduced testosterone causes the opioid receptors to be dysfunctional, and then of course the opioids aren't going to work as well. So just by replacing the testosterone in those cases can cause a reduction in pain, and maybe even a reduction in the opioid use just because you don't need as much. So I think that might be playing a role in the reduced pain that EDS patients experience. I mean, you don't have to be taking exogenous opioids. You don't have to be getting it through a prescription. Your brain also creates endogenous opioids and endorphins and things of that nature, I think, that also rely on testosterone to work. And then I would also suggest that, with Ehlers-Danlos, you have joint laxity, right, is the whole concept there. So hypermobility. Having an excess of estrogen compared to testosterone will likely cause that to worsen. This is why pregnant women, when they go to give birth, they have all this estrogen, causes all of their ligaments to distend, and the baby can then depart its mommy. But, and that's another reason, by the way, women, or especially women who've had lots of babies, let's say, have more SI joint pain, sacroiliac joint pain, because that joint is really not supposed to move a whole lot, maybe 3 degrees in any direction. But because of that prolonged estrogen exposure in your life, those ligaments are more relaxed, and the joint space will increase and lead to SI joint dysfunction. So I think that might be a similar concept also in Ehlers-Danlos syndrome. But again, I'm speaking from here, not necessarily from a study. So anyway, that's my two cents on that. Kate Bakes says, tends to go with ME, CFS, and other neuro issues as well, like POTS and functional GI, gastroparesis, cyclovomiting system. Yes, exactly. birds of a feather. These are all birds of a feather, and they definitely run together. Yep. After mold exposure, Jamie says she started to get migraines, right? And again, the migraines don't have to be related to your fibromyalgia. They can be. But again, I did an episode a long time ago talking about medical anchoring, right? And oh man, fibromyalgia is one of those things that really can be a challenge to pin down, and medical anchoring can be a big, let's call it bias that slows that diagnostic process down. And so because again, there's so many moving parts, there's so many potential causes, and so it's not about giving you a diagnosis of fibromyalgia as a diagnosis of exclusion, but you do want to do your due diligence to rule out other things that it might more likely be, or even contributing to the clinical picture of fibromyalgia. So yes, it's just one of those things you have to have patience with. Jamie, yes, phytocannabinoids help me. Yes. That is the best way to refer to. Maybe that's how TikTok and YouTube won't ban us for saying stuff like that. We can just say phytocannabinoids. Yes. And we all know what we're talking about. Yeah, again, a lot of growing research to support its use. So I'm not condemning it. I might only offer a word of caution just to make sure you know what you're getting. Because yeah, there's just a lot of variability there. Jamie says she was able to reduce her MME significantly. For those of you new to the business, that is morphine milliequivalents, also known as opioid medication. So she was able to reduce that using cannabis. And yes, she's grateful that she lives in California. And that was recommended by her PCP. So there you go. Yeah, again, just different cultures, different concepts of medical liability. I don't think we're there yet in Texas, but I don't know, maybe one day. Maybe one day. Exercise regulates the endocannabinoid system too. Yes, it does. But if one has mobility issues, phytocannabinoids has helped me. Yeah, so it may not be either or. It may be a little bit of both. Again, whatever you're capable of doing. If you're capable of spending the time and resources to throw the whole gambit at your condition, the psychosocial, the spiritual, right? The medications, the exercise, the physical aspect of it all. Yeah, man, do it. You got the money and you want to get yourself a pool? Absolutely. They have those pools that are like, I don't know, maybe 15, 20 feet long, and they have like a current and you can just swim in it. It looks like something a billionaire would have in their living room. But I mean, hey, if you can afford it, I don't think it's $1 billion, but pretty cool. I think if you can incorporate aquatherapy into your regimen. They announced Lyrica for cats in the vet world. Miracle new drug until I called the rep out. Oh, yeah. Reps don't always know sort of the experience on the ground. They come out of school and then they join a pharmaceutical company and then they get indoctrinated in all the pharmaceutical studies and, they memorize all the details of it, and that's all fair and well. But unless you're living with it or you're practicing in it for years and you kind of see the nuances and the behind the scenes sort of experiences, they don't always, know what's going on. But I don't condemn them for that. It's just you got to take them with a grain of salt. I was on Savella, Lyrica, Cymbalta, no stars, don't recommend. Flexerol gave me hangovers. Yeah. It's not for everybody. I mean, the studies that support their use, there's always a minority group that doesn't respond to it. There's always a minority group that may have contraindications or reasons why they can't take it. And so that's not to say that, coming into the field for the first time, you wouldn't stand to benefit. Of course, I do have patients that experience a night and day difference without their medication. And so, take that for what it's worth. But yes, it doesn't work for everybody. And and Flexerol, Flexerol, the brand of cyclobenzaprine that's been around forever, that we use for muscle relaxation, Yes, I definitely, man, I took that one time. I threw my back out and, oh, crazy story. I was at Home Depot, threw my back out lifting a paver. Okay. This, big old concrete paver. I was bending and twisting and lifting at the same time. I should have known better. Immediate on the ground pain. And of course I call my wife to come pick me up and she's like, well, I can't right now. I'm with the kids. I'm like, it's okay. I'll just lie here and wait. I don't want anybody coming to get me. She's like, okay, I'm going to send the neighbors. I'm like, don't send the neighbors. Next thing you know, the neighbors are there using a spatula, getting me off the ground. Yeah, no, this is a true story. I immediately get home and I'm like, oh, I don't think I can work tomorrow. I was a resident at the time. And sure enough, the next day I couldn't move. And I was like, where's my disability paperwork? I'm going on disability. My life is over. So yes, I know at least for short periods of time, what severe back pain can feel like. But the point is, I got some cyclobenzaprine. I took it and I fell asleep sitting upright in my desk chair. I was like, whoa, I don't understand how people can take this 3 times a day. Very strong medication. Now, I have not taken the new one, the Tonmya. So again, it's supposedly it is a lesser dose and it goes straight into the bloodstream, into the brain. So maybe there's less side effects there. If you've tried it, let me know. Let's see here. A lot of comments tonight. Thank you guys. Let's see, what time is it? All right, we got some time. I want to be respectful of everybody's time tonight. I think my kids too are expecting me to come home. So I'm going to get through all these comments and then we'll bid everyone adieu. Let's see, where did I leave off? Yes, cyclobenzaprine helps me with sleep, and sleep helps fibromyalgia. Exactly. But the hangover was too much. Yes. Cannabis was better. So, I might consider, if a patient were to propose that to me and all we had was the tablet, I might say you could take it a little bit earlier in the night. Maybe it wears off by morning time. You could, of course, cut the dose in half. Maybe that is a little bit more effective. But again, it's not for everybody. Okay, let's see here. Oh, thanks, Kate. Yes, I am a millennial, and it is a term of endearment, so I appreciate the validation there. Let's see. Robin says, I stayed with very low vitamin D for over 30 years. The last 6 months, he upped vitamin D to 20,000 units a day, and I noticed some days my pain became a little more manageable. Wow. I wonder if you have an absorption problem. That is a lot of vitamin D to take on a daily basis. But hey, if you need it, you need it. That's good. I'm glad that you found some relief with it. That's great. Yeah, I wonder where you live, Robin. Maybe you live somewhere where the sun don't shine, like Alaska or something. My brother's in Alaska. If you're watching, Dylan, hello. He works up there in Alaska, and kind of a interesting place. Judy Combs wonders if Amish women suffer from SI joint dysfunction. They have a lot of kids back to back. Yes, they do. I'll have to find the study, but I'm sure that there's a link between the number of children and the likelihood of developing SI joint dysfunction. But I don't want to put that in cement just yet. But yes, I think it probably exists across the board. Yeah, a lot of medications are very expensive, especially the new ones. And see, that's where my very pessimistic brain tends to go. I see this going 2 places, right? Okay, so we haven't had a medication approved for fibromyalgia in some time. So, okay, there's a market opportunity there. And we know that cyclobenzaprine works on some level for the purposes of treating fibromyalgia, and likely that's due to its effect on the serotonin and norepinephrine system. Same thing that duloxetine and Savella do as well, and tramadol, by the way. We haven't found so much good evidence with other opioids. In fact, negative evidence really with the purpose of treating fibromyalgia with opioids. If you're a person that takes opioids and find relief with it, you may just be in the minority, or you have significant additional symptoms that respond to opioids. But generally, for pure fibromyalgia, centralized nociceptive type pain, opioids tend to not do so well. Tramadol is the exception, perhaps because of its dual effect on the serotonin and norepinephrine system. So the pessimist side of me is like, okay, well, we have cyclobenzaprine, it's gone off label. Maybe we can come up with a new formulation, put it under the tongue, say it works better for absorption, which it does, get some studies that support its use, and there you go. So, again, the study shows that it works. It is, of course, an industry-sponsored study. We're still early in this process. It is an expensive medication. Is it worth trying? I think if you can pay for it, if you have it covered by insurance, yeah, absolutely. I mean, if I was dealing with fibromyalgia, I definitely won't try anything. But, that's the pessimist side of me. And it's like, okay, well, we have a growing, emerging body of evidence to support the use of, we'll call it phytocannabinoids. But are we ever going to see that come to fruition? I mean, there has to be some major political wins in this country, to make that broadly available. And then will come the challenge of manufacturing and the whole process of making sure we have a safe, consistent, and pure product that we can feel safe as physicians who carry liability to prescribe. And so I kind of see like a new medication that comes out that stimulates those receptors, that's branded, that, is expensive and all these things. I kind of see things going that direction. Similar to melatonin, what is that medication? Ramolteon is sort of the medication that stimulates the melatonin receptor. But I guess melatonin wasn't good enough by itself. Anyway, don't get me started. We don't have time. My T pulsed his back doing some sort of row, had to take a week off. Yes, you still tease him about it. Dude, there we go. Dude, it's for real. Healthcare providers experience pain too. Yay, we're on the same team. Judy Combs said, I had 3 natural births and have HEEDS, hypermobility Ehlers-Danlos syndrome. I have a lot of SI joint issues that keeps me from being able to walk very far. So painful. Yes. One of the things we're doing, this is a side note, for SI joint hypermobility or dysfunction, for the right patient who is properly diagnosed with a physical exam, a diagnostic injection, and confirming imaging, they may be a candidate for an SI joint fusion. And again, like fusion, that's a big scary word. Well, when we think of fusion, we think of the lumbar spine, and most of our range of motion comes through our lumbar spine. And so to fuse that does carry some significant consequences, whether good or bad. Fusing the SI joint doesn't have those same consequences because in our most natural state, the SI joint really is not supposed to move very much. Like I mentioned, maybe only 3 to 5 degrees in any direction. So with conditions like multiple births and prolonged estrogen exposure and Ehlers-Danlos, or even you're in a car accident. A lot of times sitting in the car, you get whiplash, and the SI joint, the sacrum moves forward on the iliac aspect of the joints, and you get SI joint dysfunction. So in those patients, we find that it's very successful, actually, in most cases, just to put 2 screws in to the joint, secure that down. It's minimally invasive procedure through an inch incision. You're home the same day, and it just locks that joint into place. Pain is a whole lot better. So I'm not saying that's right for you, but it can be right for the right person. Yes, fusions are the surgery of choice. Yeah, if it moves too much and we can't strengthen it with PT, unfortunately, fusion. But, I mean, you really can't fuse every joint in the body. I mean, you have to be quite selective with what you do there. So, all right, gang. Well, our time is up. I do appreciate you hanging out with me tonight and honoring International Fibromyalgia Day. If you have fibromyalgia and you found this talk to be helpful, do leave us a thumbs up or a comment down below. Ask us some questions. What more do you want to know? We covered a lot of ground tonight. Probably each subject could be a whole hour in and of itself. And hey, we might get into that more in the future. Until then, it's been a pleasure. Y'all take care of yourself. Until next time, take care.